Dysphagia is one of the most frequently tested gastrointestinal presentations in the MRCP examination. Questions are rarely about memorizing lists. They are about localization, recognizing patterns, and choosing the correct first investigation. Most candidates lose marks by confusing oropharyngeal with esophageal dysphagia, or by selecting the wrong initial test. Clinically, dysphagia simply means difficulty swallowing, but for exam purposes it must always be classified. There are two main types, oropharyngeal dysphagia and esophageal dysphagia, and this distinction determines everything that follows. A key principle must be established early. Dysphagia to solids only suggests a mechanical or structural obstruction. Dysphagia to both solids and liquids from the beginning strongly suggests a motility disorder. This rule alone answers a large proportion of MRCP questions. Let us start with oropharyngeal dysphagia. In oropharyngeal dysphagia, the problem occurs at the initiation of swallowing. Patients describe difficulty starting the swallow, repeated attempts, or choking immediately when they try to swallow. The sensation is felt in the throat or neck rather than in the chest. Associated features are important clues. These include drooling, nasal regurgitation, changes in voice such as a nasal or wet voice, and coughing early in swallowing. Recurrent aspiration pneumonia, weight loss, malnutrition, and neurological signs such as dysarthria are common and should immediately raise suspicion of a neurological cause. The most common causes are neuromuscular. Central nervous system disorders typically cause dysphagia predominantly with liquids. The time course is critical. An acute onset strongly suggests stroke, whereas a slowly progressive onset suggests a neurodegenerative condition such as Parkinson's disease, multiple sclerosis, or progressive supranuclear palsy. The key investigation here is a modified barium swallow, which shows early swallowing difficulty and aspiration. Neuroimaging is guided by the suspected underlying cause. Muscle disorders, particularly myasthenia gravis, also cause dysphagia, mainly with liquids. The onset is usually subacute and is associated with fluctuating weakness. Extraocular muscle involvement or ptosis is a major clue. Fibrioptic endoscopic evaluation of swallowing and manometry demonstrate weak pharyngeal contraction, ineffective swallowing, and residual food. External compression must also be considered. Patients may have a visible or palpable neck mass, and symptoms depend on the cause. A barium swallow demonstrates mass effect. Cervical X-ray may show osteophytes, while CT or MRI of the neck localizes the lesion and assesses severity. Structural causes are important exam targets. Head and neck malignancy causes progressive dysphagia with site-specific symptoms. Oral cavity lesions present as ulcerative masses. Oropharyngeal tumors cause sore throat or persistent odynophagia. Laryngeal involvement causes hoarseness, and hypopharyngeal disease often presents with cervical lymphadenopathy. Diagnosis is by direct endoscopic visualization and staging imaging. Previous treatment is another clue. A history of surgery, neck dissection, radiotherapy, or corrosive injury can explain oropharyngeal dysphagia and is often diagnosed clinically. Zenker diverticulum is a classic MRCP condition. Patients describe regurgitation of undigested food and halitosis. The correct investigation is a modified barium swallow, which shows a pharyngeal pouch. Endoscopy should not be the first test due to perforation risk. It is also essential to recognize globus sensation. This is not true dysphagia. Patients complain of a persistent or intermittent lump in the throat, which is usually painless and improves with swallowing. Pain should prompt investigation for organic disease. Globus is often associated with anxiety or reflux. Now consider esophageal dysphagia. In esophageal dysphagia, swallowing is initiated normally, but symptoms occur seconds later. The sensation is retrosternal, and coughing occurs late in swallowing. Patients may report bolus impaction or halitosis. The most common cause is esophagitis. Reflux esophagitis presents with heartburn and regurgitation. Eosinophilic esophagitis causes intermittent dysphagia, food bolus impaction, and is associated with atopy or asthma. Infectious esophagitis occurs in immunosuppressed patients and presents with odynophagia and systemic infection features. Pill-induced esophagitis follows recent medication ingestion, while radiation-induced disease follows chest radiotherapy. Upper GI endoscopy shows erythema, erosions, ulcers or plaques, and histology confirms inflammation. Management is cause-specific. Esophageal candidiasis is treated with fluconazole or itraconazole for 14 to 21 days. Functional esophageal disorders present with retrosternal chest pain and heartburn despite normal investigations. The diagnosis is one of exclusion, and management includes reassurance, avoidance of triggers, proton pump inhibitors, and low-dose tricyclic antidepressants. Structural and obstructive disorders follow a classic pattern. Dysphagia begins with solids and progresses to liquids as narrowing worsens. Esophageal cancer is a key diagnosis not to miss. Patients have progressive solid-to-liquid dysphagia, weight loss, and anemia. The correct first investigation is urgent upper GI endoscopy. Barium swallow may show an apple core lesion. Management depends on T&M staging. Esophageal strictures cause intermittent or persistent solid food dysphagia. Barium swallow shows concentric narrowing, and endoscopy confirms the diagnosis. Management is endoscopic dilatation and treatment of the underlying cause. Esophageal webs and rings cause long-standing, intermittent solid dysphagia. Barium swallow identifies the defect. Proximal defects suggest webs. Distal defects suggest Schatzky rings. Management includes iron replacement in Plummer-Vinson syndrome and endoscopic dilatation if symptomatic. Esophageal diverticula cause regurgitation of undigested food and halitosis. Diagnosis is by barium swallow, and management is surgical or endoscopic. Extrinsic compression presents with solid dysphagia and features of the underlying cause. Barium swallow shows mass effect, and CT, MRI, or echocardiography identifies the source. Motility disorders cause dysphagia predominantly with liquids or with both solids and liquids. Symptoms may be intermittent or slowly progressive and may worsen with cold food. Hypermotility disorders cause intermittent dysphagia and episodic chest pain. Manometry shows hypercontractile or premature contractions, and barium swallow may show a corkscrew appearance. Management is symptomatic with smooth muscle relaxants. Achalasia is a classic MRCP diagnosis. Patients have dysphagia to both solids and liquids, regurgitation of undigested food, weight loss, and halitosis. Manometry shows absent peristalsis with increased lower esophageal sphincter pressure and incomplete relaxation. Barium swallow shows the bird beak sign. Management options include pneumatic dilatation, Heller myotomy, botulinum toxin injection, and nitrates. Scleroderma must be contrasted with achalasia. Dysphagia is slowly progressive and associated with severe reflux and crest features. The key distinction is that lower esophageal sphincter pressure is reduced, not increased. Manometry shows reduced or absent peristalsis, and barium swallow shows a dilated esophagus. Management focuses on prokinetics such as metoclopramide or erythromycin. An emerging MRCP concept is opioid-induced dysphagia. Opioids can cause esophageal hypomotility by impairing peristalsis and altering sphincter relaxation. Finally, the most important examination rule concerns investigation. In dysphagia, the default first-line test is urgent upper GI endoscopy to exclude malignancy. However, in high or oropharyngeal dysphagia, the correct first investigation is a barium swallow. Barium swallow is also preferred when a motility disorder is suspected or when endoscopy is unsafe. It is crucial for detecting a pharyngeal pouch, which can be perforated if endoscopy is attempted blindly. MRCP key points and exam traps. Always localize dysphagia first. Solids only suggest structural disease. Solids and liquids from onset suggest motility disorder. Oropharyngeal dysphagia requires barium swallow first. Oesophageal dysphagia requires urgent endoscopy first. Achalasia has increased LES pressure. Scleroderma has reduced LES pressure. Zenker diverticulum is diagnosed by barium swallow. Never scope blindly in suspected pharyngeal pouch.